This is, I believe, our 10th MLCC webinar, and we are very happy to have this presented and funded by the Maine Lung Cancer Coalition, truly working together to reduce lung cancer in Maine. The funding for the Maine Lung Cancer Coalition, we have Bristol Myers Squibb Foundation, the Maine Cancer Foundation, and the Maine Economic Improvement Fund. Today, we are so excited to have Dr. Jamie Stutz with us today. We are, and the title is, What is Quality Implementation of Lung Cancer Screening? Thoughts on Optimizing Community-Based Implementation. Just a few housekeeping before we roll into the presentation. Audio lines for non-presenters are currently muted. Please use the chat box for any questions that you have or comments throughout the presentation. We'll be monitoring them. Dr. Stutz will be monitoring them as well, and we'll be addressing those as needed as we go along. And depending on where we're at for time, we may address them at the end of the presentation as well. If you are requesting CME for this webinar and you did not sign into Zoom through a direct link, or you're watching as part of a group, if you could please email mlcc@mainequalitycounts.org during, immediately, or after the webinar so we can track your participation. That would be terrific. You can also put your name and title and those that are attending in the chat box as well. For speaker disclosure and CME certificates, the speaker today does not have any relevant financial relationships with the manufacturers of any commercial products and or provider of commercial services discussed in the CME activity. A CME evaluation survey will be sent after the learning session via email. Please complete the survey via SurveyMonkey within 1 week, and a CME certificate will be mailed within 1 month of completion of the survey. So today, we are so happy to have with us, again, I had mentioned Dr. Jamie Stutz. He is a professor of behavioral science at the University of Kentucky College of Medicine and assistant director for cancer prevention and control with the Markey Cancer Center. He is a licensed clinical health psychologist, and his interests address behavioral aspects of tobacco-related malignancies. His research develops and tests interventions to promote informed and shared decision-making and behavior change among patients and clinicians regarding prevention, screening, and survivorship of lung and head and neck cancer. He's the principal investigator of the Kentucky Leads Collaborative, and I will let him go into more detail on that. But again, we are so happy to have him, and thank you so much for joining us today, Dr. Stutz.
Okay, thank you very much, Jessica. Can you guys hear me?
We can.
Terrific. Thank you very much. So I'd really like to express my appreciation for the invitation to give this presentation from the Maine Lung Cancer Coalition and the leadership there, Paul and crew. And also, Danielle, thank you for your patience throughout the preparation for this presentation. So I really appreciate the opportunity to talk with you about quality implementation of lung cancer screening and some of the things that we've been working on here in Kentucky. There's a tremendous amount of overlap in our communities that we serve in terms of a heavily rural population that's at risk for lung cancer. And so I think that there's a lot of synergy between the efforts that are going on in Maine as well as those here in Kentucky. With low-dose CT for lung cancer screening, offers a true paradigm shift in taking care of individuals who are at risk for lung cancer. With the promise of the data from the NLST and the Nelson trial, as well as the policy that's been put forward with regard to the Preventive Services Task Force and the Centers for Medicaid and Medicare Services, we think we have a pretty good chance to start to transform some of the tremendous burden that we've had in lung cancer mortality, and to really to turn the corner on quite an opportunity to reduce that. But the next challenge becomes the implementation phase, where we're taking and translating this into community settings from the National Lung Screening Trial. And of course, this presents quite a number of issues to make sure we're maximizing that impact while at the same time minimizing the potential harms of lung cancer screening. Unfortunately, from the National Lung Screening Trial, we do know that there is a substantial rate of potential harms and a diversity of harms that we really do need to manage. Now, with good management and good fortune, we'll be able to continue to put those two curves or separate those two curves toward increasing the benefits and reducing the harms. So with today's discussion, I want to talk about some of the early thoughts on what involves in terms of delivering quality lung cancer screening, examine some of those elements of quality lung cancer screening, as well as considering some approaches to advancing the science and practice of lung cancer screening. So people are probably fairly familiar with this figure showing that there are two definitely different curves for both the reduction in lung cancer mortality, comparing the low-dose CT arm to the chest X-ray arm in the National Lung Screening Trial. That was followed by the establishment of guidelines, primarily by the U.S. Preventive Services Task Force, and then ultimately having funding coverage tied to that from the Affordable Care Act policies, as well as the Centers for Medicare and Medicaid Services. And really where we go from here with that wonderful combination, that wonderful foundation of data, policy, and financial supports is really the next phase, is actually making sure that our communities and our individuals at high risk have access not only to lung cancer screening services, but high quality lung cancer screening. And it's really hard, translating that NLST and now the Nelson trial results, and making sure that our communities, in particular through the window that I see the world here in Kentucky, making sure that from Paducah to Pikeville really have that same opportunity to participate in lung cancer screening. Now, we do know that data has not necessarily been on our side with regard to implementation and uptake. And these are data from two separate studies that had data on lung cancer screening uptake prior to the implementation of publication of the NLST and implementation of some of our guidelines to those that are after. And whilst one of these studies showed a statistically significant increase in uptake of screening post publication, you can see that we are dramatically suboptimal in our ultimate implementation to date with regard to lung cancer screening. Now, why is this so low? Well, first off, I think we have to say that translation takes time. And we all know this in terms of the length of time it takes to translate an evidence-based intervention from publication all the way to make sure it perfuses throughout the community tends to take a long time, and we need to shorten that as much as possible. But also, I think that we suffer from a field of dreams fallacy. As a native Iowan, I'm familiar with the field of dreams. We really thought that if we built it, they would come. And in terms of lung cancer screening, I think it's proven not to be the case, that in fact we have to do lots of things to help support the community in understanding the value and the benefit and building engagement in lung cancer screening. And so with colleagues here, we've tried to adopt a more of a socio-ecological model of understanding lung cancer screening, and by expanding awareness and working at a lot of different levels of the challenge. And I know that some of this work is also going on in Maine, but to work with community members to enhance their awareness, whether they're at high risk or not, partnering with organizations and healthcare systems that have unique ways of reaching individuals, as well as encountering clinicians and helping support their integration of evidence-based practices within systems and with electronic health records, but also outside of electronic health records to integrate these new tools that we have to reduce lung cancer mortality. Similarly, we do also want to target screening eligible individuals, but these aren't the only people that we need to be reaching out to. Sometimes it actually may be a more effective strategy in terms of quality lung cancer screening outreach to help expand knowledge and awareness among individuals who aren't at risk, so that we can share that knowledge and have that knowledge spread and once again perfuse throughout the community to create a somewhat different social norm of screening, somewhat similar to what has been achieved in other cancer screening domains. Our approach that we've taken to expand awareness has tried to reduce the reliance on fear appeals, on stigma appeals, or blatantly rational appeals. And we're actually trying to find ways of genuinely supporting and building interest, curiosity, and engagement with lung cancer screening to try to avoid the development of and playing into the natural fears and stigma that individuals who are at high risk for lung cancer, let alone the fatalism that many people experience with regard to lung cancer outcomes. Now, as people working in this field, we probably have a different perspective with a lot of the excitement happening in the world of lung cancer prevention, control, care, and survivorship, that we're trying to turn the corner again on building optimism and hope and with these new opportunities. But at the same time, we really think that we need to get that out in the community. One of the other challenges also that I'll highlight a little bit later in the talk is that screening is a new thing for many people in the lung cancer prevention, control, and care domain. Unlike our colleagues that work predominantly in breast cancer or colorectal cancer, where there's been decades of work that has been dedicated to understanding the complexities of the screening environment. We have a lot of work to do in the same to develop the same foundation of awareness of some of the engagement challenges and some of the clinician challenges and some of the system challenges to delivering high quality lung cancer screening. And in many ways, our teams aren't really based or have a foundation of experience in screening, and so that will take some time to develop, and educational efforts will be an important part of that equation. Another one of the major threats to lung cancer screening involves adherence. Now, the slide that I've presented here depicts the adherence to the protocol in both the low-dose CT arm and the chest X-ray arm, showing nearly 95, but definitely over 95% adherence to the entire protocol with regard to implementation of the screening algorithm. Whereas programs A and B are actual data from programs here in Kentucky that have been willing to share their adherence data for folks coming back at a single year after baseline. And quite literally, there is no way to achieve the population benefit of lung cancer screening with adherence rates this low. And I think that that's been one of our most significant challenges. We've been very concerned, and rightly so, that uptake has been so suboptimal, but adherence has been perhaps even worse. And with the lack of adherence, lack of retention, we run the risk of causing greater harm than potential benefit. And I'll talk about a little bit more about that in a few minutes. And in terms of one of the definitions that I have for quality lung cancer screening, it involves efforts to engage that are empathic and indeed feasible for programs to implement, ways to partner with this community of individuals at high risk that suffer from some degrees of stigma, some degrees of stress, some anxiety, some very high risk perceptions with regard to lung cancer screening and lung cancer risk. Often the model we have for understanding lung cancer is that we identify the high-risk lung cancer population, we apply lung cancer screening, and we reduce lung cancer mortality. When in reality, it's quite a bit more complex. This community of individuals is new to screening in terms of the high-risk population, and that in reality, our efforts to engage them with informed and shared decision-making, and as well as patient counseling on the role of adherence and tobacco treatments, plays a vital role in facilitating that engagement, supporting the patient autonomy, and developing trusted relationships that then translate into adherence, and that is then the pathway toward mortality reduction. Building on that data that we just saw a second ago, I think we're skipping perhaps some of these steps and not honoring some of the counseling efforts and some of the engagement efforts that are truly necessary to optimize outcomes from lung cancer screening. Further, we add tobacco treatment and radon education and other exposures into the mix in our counseling sessions in order to advocate for other pathways toward mortality reduction. Focusing on these other evidence-based strategies to reduce lung cancer mortality and mortality from other factors. But it also helps us build relationships, we believe, because it helps us diffuse some of the anxieties and concerns and stigma with regard to a sole focus on tobacco. And all this is founded on a basic and fundamental understanding that the lung cancer screening population is a unique one that likely requires substantial engagements efforts in order to achieve optimal outcomes. We know that there's been apprehension to the requirement to do shared decision making in advance of lung cancer screening, and that perhaps folks don't quite believe as much as the founders of that policy in a role of shared decision making, whether you buy into that process or not. I do believe that it plays a very strong role in building engagement and adherence. And so even if there is some apprehension on your part that informed decision making or shared decision making is more of a barrier to actually getting the screening conducted, I think I challenge you to think of it differently as a way to allocate time that is reimbursable toward developing a relationship that really optimizes the chance of that any one individual having a more favorable risk-benefit profile with regard to lung cancer screening. So one of the ways I think about lung cancer screening is through the lens of clinical and translational science. And, we have the evidence that lung cancer screening works. So we are now in that translational phase. We're in the dissemination process of trying to figure out the specifics of how we can make sure that what was done at large hospital systems reaches out into the community hospital setting so that more people can benefit and have access to those high quality services. And I believe that implementation science is one of the major pathways to do that. Sort of adjacent to quality improvement, but a different way of systematically thinking about the implementation of lung cancer screening and contributing to its ongoing development. And the fact that we are seeking to understand the barriers and facilitators that influence successful implementation of the effective lung cancer screening intervention. I'd like to think that question's been asked and answered, but really it's making sure that folks have access to those services, and through a variety of processes in terms of expanding community awareness, provider training, patient education efforts, high quality implementation of lung cancer screening, and then rigorous and attentive patient care and patient management for those individuals who have suspicious results as well as frank malignancy, to making sure they're followed effectively and receive the care that is best suited for them and achieves the best outcomes. So one of the things that we're most worried about in translation is actually degrading the effects as it transitions from a tightly controlled randomized clinical trial or into community implementation. And that can be due to a number of things. In terms of resources that are available for a grant, as you may know, the $250 million were spent to support the conduct of the National Lung Screening Trial. Of course, that's a huge outlay of resources that may not be able to be implemented or modeled at sites, and yet we need to find ways to make sure our communities have access. The expertise is one consideration, that low-dose CTs are somewhat novel for many radiologists, and so gaining that experience and that training to feel comfortable and confident in both the reads as well as managing pulmonary nodules. The effort, as I've talked about, in terms of engagement and rigorously following patients, both who have higher lung RAD scores, and making sure that we support their efforts to re-engage and do the recommended follow-up as well as return for annual follow-up, and then a constant and vigorous dedication and motivation to improving outcomes. And we can turn that anxiety about degradation into actually acceleration, because there are things that we've learned already and made slow changes in lung cancer screening implementation that may actually improve the outcomes in the community over what we saw in the National Lung Screening Trial. And so I think one of the one of the awkward quotes that I've used is, hopefully we will never do lung cancer screening as poorly as we do it today, meaning that we have opportunities to use the data that we're collecting, to use our experience on a daily basis to continue to improve and refine these outcomes by working with frameworks, identifying the need for community-based metrics and evaluation systems, and then a constant striving to improve those outcomes to maximize the benefits and the reach of lung cancer screening. I want to talk about just a few more other threats to the translation, and perhaps speaking directly to the uptake and adherence issues, in that I believe that a pervasive, persistent, and toxic presence of lung cancer stigma really hampers our uptake and implementation. And so while it may not be a direct impact of stigma on screening and screening quality and optimization of delivery of services, it certainly has an impact on patient flow and their ability to engage with us. And then, of course, I've talked about the time and effort and resources to adapt the NLST and to learn and refine those approaches and to build proper educational systems so that we can assure that the radiologic assessment is both reliable and valid in terms of the reads that we're receiving from radiology, and that the navigation and engagement is in place to support adherence, to respond to challenges, respond to problems with this unique community of individuals. And then finally, that all can translate into suboptimal and or unfettered screening. So I think perhaps one of the biggest problems right now in terms of achieving the potential benefits of lung cancer screening is underscreening, simply not getting the community at risk to engage with our services in what we're trying to do with lung cancer screening, and not being aware or being quite apprehensive about doing so. But the other thread is overscreening. In many of the policy statements, and indeed the data and reanalysis of data, suggests that we have to be very cautious, if not extremely cautious, about overscreening, about screening outside the guideline recommendations where we don't have strong data to support the value of those of benefits greater than harms. And so we have what is Goldilocks screening, that is just right in that sweet spot where we can where we have data to be very confident that our systems are likely to deliver more benefit and reduce harm to individuals. So transitioning into a more directed discussion about what is quality implementation of lung cancer screening, I want to say that I was really appreciative of the invitation to talk about this, because it is largely opinion. And I can honestly say that I don't know for sure what quality implementation is, but also I don't think anybody really knows for sure, because we simply don't have enough experience with it now in community settings to know what the optimal strategies are. And therefore, we need to be collecting data along the way to continue to refine and learn, and to share that data across systems and across regions in order to optimize lung cancer screening. However, we have a few ideas about possibilities, and so we can go ahead and get started with discussing those. The primary sources that I draw on to inform our efforts to achieve quality implementation of lung cancer screening in the Kentucky Leads group, of course, begin with the data sources, not just the National Lung Screening Trial, but of course the PLCO trial, showing that chest radiography plays no role in improving outcomes from lung cancer. We also, of course, have the policies that have been developed based on those. And we also have quite a few guidelines and areas of supporting excellence. We have additional thought pieces and reflections from the National Academy of Science and Medicine, as well as very invested and engaged partners of our professional organizations, including the American College of Radiology and advocacy groups like the American Lung Association has put out some recent policy guides. But I also think that it's equally important that more regional efforts be supported and deliver data on how to optimize lung cancer screening regionally. We have some unique challenges in Kentucky. You have some unique challenges in Maine that may be very important to optimizing lung cancer screening operations in a more regional manner. And then finally, as we go forward, the more data, once the Nelson data has been presented showing very favorable results. We're waiting for the publication of that data. And most recently, we had an Italian study that has been reported on the longest term outcomes of lung cancer screening of an early trial that did not meet its initial goals, but at 10 years has shown a very substantial mortality reduction from lung cancer, showing the long-term value of lung cancer screening, and it will be hopefully contributing to our policy landscape as well. I mentioned before that I believe that lung cancer screening, that the operations of lung cancer screening are often based on what we might call the rational model of screening in general. Is that you identify a high-risk candidates, you conduct your lung cancer screening, you identify pulmonary nodules, you perform those follow-up diagnostics, you get the chance to detect that lung cancer early, you treat it early, and you reduce lung cancer mortality. And it all works in a very systematic fashion. And that's sort of an ideal world view of things. In reality, my experience has been much, much different. That the pathway can kind of circle back onto itself and takes a few deviated courses along the way, and can be quite a bit more challenging when interacting with this unique group of individuals at high risk, and it takes quite a bit more to manage that trajectory. But to do so, we have some guidelines. And of course, I think the foundation of what we have to proceed with is the National Lung Screening Trial. And to optimize our outcomes, I think we're best to stay as close to that trial as possible with how we're implementing lung cancer screening, both in terms of the eligibility criteria, but also trying to emulate some of the management approaches that were available, and there's some of the engagement approaches. Now, the resources, of course, were available to try very creative and innovative things to both accrue folks to that trial and to retain them in that trial. And so I think there are some cues that we can use in terms of high quality patient navigation that is very invested, so that when someone who's participated in our screening program gets a call, it's preferably from someone they know, someone they met, and say, Jamie, it's time for scheduling your annual lung cancer screening. What time frame would work best for you? And if that response comes from someone that is connected, I think that there's a much higher likelihood on following through on that. Now, we know that this trial was a little bit adapted and shortened because of for somewhat good reasons, and the fact that it met the closure boundary early for benefit, in terms of a benefit being identified early from lung cancer screening, so they stopped screening a little bit earlier. But unfortunately, that precludes our understanding of what longer-term screening might look like in the context of the lung screening trial. But I've already been through this data, shown it to you in a slightly smaller context, but you can obviously see those benefits are there. But we also have some harms to deal with, and we have to navigate those. And that provides a bit of a roadmap for and justification for why some of the elements of some of the CMS policy are perhaps different, as well as some of the stronger recommendations coming from the Preventive Services Task Force, as well as virtually every organization that has come out in support, and even one organization that has come out not in full support of lung cancer screening has recommended informed and shared decision-making procedures as the vital aspect. One of the lesser attended to aspects of the CMS recommendation is counseling for the importance of adherence. And I want to highlight using this data, using this more lung cancer mortality data from the NLST to kind of highlight why adherence is so critically important. So the question I'm asking is, where is the effect of lung cancer screening, or when does it emerge? Does it indeed emerge after year one? Well, in fact, no. Those two curves are almost exactly the same. By year two, well, yeah, we're starting to see some differentiation in the latter part of the second year of screening, post-screening, post-baseline screening. But in reality, it's not until the third year, or after having conducted several scans, that we're actually seeing that differentiation in those two curves that is sustained and expanded by the follow-up in year 6. And this is once again why adherence and engagement become a vital element of lung cancer screening, and that one of our ideas that we are supporting and testing is the idea of developing person-centered lung cancer screening programs that meet the unique needs of individuals in terms of their engagement and participation in lung cancer screening in a quality manner. I have to highlight just one thing to make sure that people are abundantly aware that chest radiography and chest x-rays play no role in lung cancer screening. They're not a backup strategy. In fact, here in Kentucky, we have efforts of trying to de-implement chest x-rays for lung cancer screening in our primary care community that had been ordering them still up to 10 to 15% of the time, in actuality possibly exceeding their referral rate for low-dose CTs. One of the earliest efforts to put a framework around the lung cancer screening process came from the Lung Cancer Alliance and their framework for excellence in lung cancer screening and the continuum of care. And they really starting to talk about the patient experience, which I think was a very important element, as well as the central role of nurse navigation. Now, I'm less interested in the discipline of who is doing that navigation, as opposed to the level of engagement that they can generate. I fully believe that lung cancer screening, at least at its current state and for several years into the future, will be a high-touch endeavor. And that these are folks that we need to get to know and get to know well in order to support them until we can transition into a situation where we have more social acceptance, more social awareness, more of a social norm or a culture of engagement with lung cancer screening. And I've already mentioned, but the U.S. Preventive Services Task Force, building on the NLST data as well as some others, gave that B recommendation that allowed us to go forward with transitioning to implementation of lung cancer screening on a national basis. And as many of you probably know, the risk status is fairly consistent with the NLST, but there were a few differences, including the addition of a couple years on the end of the eligibility criteria based on some modeling that they did. But it also calls specifically for the integration of tobacco treatment strategies, and specifically calls for a recommendation for shared decision making. But it also went further than that in a few other areas. And so while the eligibility was one area, and providing guidance about when to conclude screening, it also talked about smoking cessation counseling both in the primary care setting as part of the shared decision-making consultation. But I think some of the times that people are missing out, that is also heavily encouraged to be an element and part of the lung cancer screening program itself. The shared decision-making task was justified based on the fact that the benefits vary by risk. There is not some very compelling data showing that those at lower risk, even though eligible for the National Lung Screening Trial, have a much lower risk-benefit ratio differentiation there, whereas those at the highest quartiles or quintiles of risk really are the ones that are gaining the most benefit from lung cancer screening in terms of reduced mortality. And finally, then there's a call to standardize the low-dose CT screening and follow-up of abnormal findings to make this as rigorous as we'd like it to be. There was some flexibility in the National Lung Screening Trial that they've tried to shore up in later years with the development and implementation of LungRads, which is the coding system and communication system for lung nodules, and as well as plans that are for the management of those nodules and treatment of malignancy, making sure that none of those folks fall out of our systems, and making sure we're supporting them. The other thing that the U.S. Preventive Services Task Force called for and initiated discussions about was the development of a registry to monitor implementation of lung cancer screening and perhaps serve as a resource for continuous improvement of lung cancer screening. The National Comprehensive Cancer Network is another outstanding resource for information on implementation of quality lung cancer screening. And it is one of the highlights of this document is it rigorously reviews the literature and updates this on an annual basis, led by Doug Wood at the University of Washington and a team at the National Comprehensive Cancer Network. Now, there has been some discussion that the NCCN guidelines extrapolate from high quality evidence to include a second category of individuals that are deemed to be also at high risk, but there's not level 1 evidence to support the value of lung cancer screening in that population of individuals. Now, some of the strength and guidance toward quality implementation that are provided by the National Comprehensive Cancer Network guidelines involve an extensive lung cancer risk assessment algorithm integrating occupational exposures, radon exposures, and other factors that may be contributing to long-term lung cancer risk. They also provide very elegant, detailed nodule assessment and follow-up algorithms for clinicians in terms of their expectations and how best to support communication. A rigorous discussion of the latest data on potential benefits and as well as those potential harms and the data and unknowns that we aren't aware of yet or in terms of the long-term consequences. And so they take a look at that data very rigorously and be able to present it back with quantitative information in some cases that can really make a strong contribution to our patient counseling efforts. And like I mentioned before, it's frequently reviewed and revised. Now, the one comment or question, and there's a lot of different discussion going on about this, is the differentiation between their group 1 is the traditionally eligible individuals following those eligibility criteria, and then the group 2 or the expansion group of individuals where the NCCN accepts these folks as at risk and at sufficient risk with adequate evidence to favor screening in this population of individuals at age 50 with a 20-pack year exposure, as well as an additional risk factor. But they do document that there is not ideal level of evidence for that conclusion. In 2015, another group put together a broader concept of what is quality lung cancer screening and made this 10 pillars model or framework, which I thought has also made a really nice contribution. And they focus on some of the similar themes of eligibility, education, the exam ordering process, the imaging acquisition and reading, but also they highlight the communication and the development are needed around the referral network, constant quality improvement efforts, challenges and resources for reimbursement, and then continuing to do research and expand the frontier, whether it's learning more about who would best benefit or other strategies to maximize benefits for patients. I tend to want to break this down into different elements that are involved in the pre-screening process, the peri-screening process, the post-screening process, as well as those factors that are prominent throughout the screening trajectory and things that need to be considered along the way. recognizing the complexity of implementing this new innovation from the, born of the National Lung Screening Trial and other observational trials in the past conducted by the LCAP group, and that this was going to be a challenge to get out into the community for broad access. The National Cancer Policy Forum organized a meeting and a workshop on the implementation of lung cancer screening, and you can see here from that document, which you can download for free from the National Academies, that there's a very similar pattern of concerns, of areas of, what is the evidence? How can we populate these patient counseling sessions with information and support for patients? What are the ideal boundaries for eligibility and clinical practice guidelines? You can see also significant attention to some of the parallel items around shared decision making, structured reporting, and structuring lung cancer screening programs, making sure that they're focused on quality, and then integrating some additional services, because we know that integrating tobacco treatment and smoking cessation into these makes them even more cost effective. There's strong data to support that, but also give rise to a higher degree of value and efficiency in the lung cancer screening process. So lots of good details and information about quality implementation in the National Academy's document. One of the other tools that has come out led by Peter Mazzone and a group from the ACCP and ATS to put together this and to start to transition from concepts to more specific issues, and they put their seal on this national consensus work on what is quality lung cancer screening. And once again, there's lots of parallels that's starting to emerge across these different ways of thinking about lung cancer screening quality implementation. And so this is a really, it takes it to another level of starting to put some information around and set standards by which we could potentially work to meet. This, in 2015, despite some concerns and apprehension, and actually an initial determination that suggested against adoption of lung cancer screening or financial support and policy coverage for lung cancer screening. Ultimately, CMS favored lung cancer screening, but they also put a number of stipulations and boundaries around it for some of the same concerns that we've talked about already. You can see they asked that with an LDCT-based screening in primary care, the initiated process, that there must be documentation of eligibility, documentation that a shared decision-making consultation occurred with the use of a decision aid, that there had to be documentation of addressing adherence and screening counseling with the individual, and that for those individuals who are still using tobacco at the time of screening consultation, the service that they must be delivered an evidence-based tobacco treatment intervention. But again, CMS went a little bit beyond those things that have become fairly well known to include other pieces. And they added some eligibility with regard to the radiologist, including board certification, experience or expertise having played a role in over 300 chest computed tomographies in the past 3 years, documentation of CE, and including providing these through a radiology imaging facility that meets additional criteria. So with regard to the imaging facilities, you can see that performing the LDC with appropriate volumetric doses and using standardized lung nodule identification, classification, and reporting systems. And then this is where they require the formation and delivery of information to the CMS approved registry, which is run by the American College of Radiology. So I just noticed a couple of questions that have popped up that I wanted to take, that I will address in just a couple of minutes after I get through the next couple of slides. So the American Lung Association, one of the most recent documents with regard to quality implementation and other operational factors, comes from the work of the American Thoracic Society and the American Lung Association to offer this implementation guide, which provides some directions, but also a lot of stories about the experience and what people and screening programs have been doing across the process. Things like, that they're using strategies that they're using before the screening, during the screening, and after the screening, as well as strategies for integrating smoking cessation and tobacco treatment. There has not been a lot of guidance yet on tobacco treatment. The NCI has supported a number of different research projects to find optimal ways of integrating tobacco treatment. Until we have more data on that, we have some pilot data from Kate Taylor and some other colleagues looking at and showing that there's some potential, obviously, for integrating and to really utilizing this as a teachable moment to leverage some additional motivation to support tobacco treatment and move the needle in that way forward as well. The American College of Radiology also has a suite of tools that are available to achieve screening center of designation, as well as the you can download those lung rads materials to make sure that your group is following those, contributing to the lung cancer screening registry. And they also have a suite of educational materials and videos you can download or access to for your team. So I want to touch on a couple of the questions that have come up. So the question is, would you discuss the recommendation to stop screening at 15 years after quitting? That is an epidemiology-driven decision and is proposed in the U.S. Preventive Services Task Force guideline, and that is their best estimate of when those risk-benefit curves start to transition in the other direction. And of course, this also comes from the NLST guidelines that showed that individuals who had quit for over 15 years were not eligible. So that was driven largely by epidemiologic data, and only time will tell. And we have folks certainly that are very interested in that question, and we're monitoring that. And that really supports the value of the registry process and as well as pragmatic trials that will allow us to evaluate the longer term effects of persistent lung cancer screening over a period of years. And that could change as we try to reduce some of the harms and maximize some of the benefits that could see that going in a different direction. And then there's a second question about, can people under the age of 55 get lung cancer? And of course that they can. It is, and I assuming that is going towards the direction of why aren't we screening younger folks? Well, the fact is that there is an iceberg effect that occurs as you go younger, and we have data to show both from the NLST and other areas that as we go younger, and with less exposure and less risk, we are more likely to harm individuals with screening than we are to benefit them. Now, I don't use that to say that we should never be screening individuals outside the eligibility criteria. I just believe personally that it requires even a higher level of understanding and a commitment to share decision making so that folks know and understand. They're also very unlikely to have that screening paid for because it's not a substantially evidence-based screening to screen outside the guidelines. But if indeed they're willing and wish to pay for it out of pocket and fully understand the benefits and harms, that is also a shared decision-making process that can be made among those individuals to pursue screening outside the guidelines. So I want to transition back to discussing high-quality lung cancer screening and somewhat more of the approach that we've started to take in understanding that implementation of lung cancer screening here in Kentucky. And we break it down across that socio-ecological model, working from communities to the national space. And of course, we have efforts working to expand awareness, to work on engagement and preparing people for the process and helping them understand, and then providing strong management along the way. There's lots of groups that touch the lung cancer screening process that require additional skills and expansion and systems that can support the high quality implementation, whether it's adapting electronic health records to make sure that we're collecting high quality data with regard to pack years. That's a very challenging concept for many folks. It's not just evaluating it, but collecting it or reporting it. And we see some variability there. It's not a great measure of exposure, but right now it's the best we have. Hopefully future efforts can be help to with biomarkers to help really get a better handle on exposure criterion that can improve that process. Healthcare systems and making sure that our systems have the adequate educational supports and structures to support thorough screening and navigation across the way, and then monitoring and feedback to sites along the way to make sure that they're understanding how are they standing up to national metrics on implementation or on management of lung cancer screening programs. And that's why we've adopted some themes around a person-centered approach, as well as a very community-engaged approach that we think maximizes the potential of our lung cancer screening programs to achieve those broad effects that could be realized through lung cancer screening on reduction of mortality. So in terms of turning this challenge into an opportunity, we really believe that that person-centered approach is what is going to help us transition to that. But what do I mean by a person-centered lung cancer screening approach? I think that it is first and foremost a fundamental approach that respects the patient autonomy of choice. I think that many of our strategies often use persuasion tactics, and we often replace the motivation of the patient with our motivation, and I think that leads to a situation where there's less motivation, less likely to be adherent and benefit from the system. And systems design that acknowledge and respects the unique context of the individual. These are many folks are first-time screeners, first-time understanding the screening process, and have not been always treated optimally by our healthcare system, and we have to understand that and work to overcome some of those challenges. And by tailoring our approaches to understanding about the individual needs of participants and being able to manipulate how we interact with them and meet their individual needs to maximize their engagement. I mentioned as well as a focus on engagement over compliance and the high touch endeavor that is been shown to be effective in helping people engage and adhere to longer term participation. I mentioned before as well that integrating comprehensive lung cancer risk reduction efforts may actually diffuse some of the challenges or sensitivities around the pure focus on smoking as a risk factor. By including a discussion of radon, we believe there's a destigmatizing, a diffusion factor, and it's an evidence-based strategy to educate people about radon exposure and help them get test kits or perhaps even move further down the line toward mitigation if indeed there's some questions about too many picocuries of radon exposure in their radon gas exposure in their homes. I think we also need a systems approach, a multi-level design, making sure that our systems are working effectively with clinicians and with the patients and perhaps even the caregivers and family support systems to support implementation. I think there's also some fundamental things that we assume in the process of communicating some of the most fundamental aspects of the lung cancer screening program. One of the things that my colleagues with some additional funds from the Bristol Myers Squibb Foundation with colleagues at Longevity are looking at ways of developing more acceptability and more feasibility within our communication systems to help people feel affiliated with a screening program and increase their engagement. I think there's a constant search seeking of high delivery and high quality services, and that we have to really champion multi-level and possibly multi-channel communications. I think that communication may be one of the most serious points of concern in making sure that all of our clinicians and all are communicating with patients and systems to make sure that folks understand where they are in the process. And then finally, it probably includes quite a few other things that I haven't thought of yet, but I think that's emphasizes a process of learning that we're all going through in terms of offering lung cancer screening and optimizing those outcomes. So I want to transition again to talk a little bit more specifically about the Kentucky Leads Collaborative and the investment that we have made of time and energy into providing high-quality lung cancer screening in Kentucky, and what we're trying to learn about Kentucky implementation of screening by offering some resources and training and feedback on quality implementation in order to optimize outcomes. So what we've done is we've translated a lot of the quality material that's been developed, a lot of the beliefs, a lot of the systems that were used in the National Lung Screening Trial into a study resource portal, as well as an evaluation system where we can actually audit that data and provide feedback, as well as goal metrics for people for sites and programs to achieve in order to improve their score and with theoretically linked to quality implementation. So we've developed what we call the QUILS Index, which is the quality implementation of lung cancer screening. It is 6 primary areas where we've consolidated some of the work that other folks have done to look at different areas of different elements of it, from the radiology to the screening, to the operational teams, to the prevention efforts, education efforts, and then community outreach. And what we've done, excuse me, is that we've translated these things into quantitative numbers so that we can actually give feedback to the sites. We start with doing structured interviews to collect information, but we also have a data collection system that allows us to track how much and what areas they're doing and automate the system so that we can get accurate data into our common database and then back out to the sites. We know that this will be an iterative process throughout, and that QUILS 1.0 is wrong. It's like any initial effort, any model. We know that we're working toward revising it and refining it already, thinking of new ways that could be linked with quality. But really what we're trying to do is to establish this as a metric and then come back and take a look and compare the data and make sure that that QUILS is actually related to outcomes. So here's an example of the structured clinical interview that we use to collect data on the lung cancer prevention efforts. It'll no time to go through that in detail, but you can see it in the slide deck. But in terms of the algorithm that we use, you can see that the Leads Collaborative Prevention Early Detection schematic involves baseline data collection, where we do a site visit and provide feedback at every 6-month intervals, and they will have access to our resources. And then we'll go dark for 6 months and then evaluate their retention on those metrics and see if they're able to sustain it without access to any of the technical assistance or supports that we provide. So I want to close with a final admonition or belief that we have a really unique opportunity in lung cancer right now, not just in early detection, but across the spectrum to harness innovations in prevention, early detection, diagnosis, treatment, and survivorship. But lung cancer stigma and beliefs that this community is somehow different and less deserving is the cloud that is going to, in my opinion, destabilize or reduce the likelihood of us receiving these benefits. And so we really have to find ways in all that we do to reduce that stigma, to provide better access and better services. So while we have a large array of information, data, and perspectives to inform quality implementation, there's still a lot of work to be done to define exactly what that is. That implementation science, while I haven't gone into details about it, is really our best effort of making that transition from the randomized clinical trial to our communities, and that more national and regional data are needed. And that's why the efforts in Maine and Kentucky can be such a vital vitally important in terms of reducing lung cancer mortality in both of our states, but also informing other like states that have a similar burden. And that we continue to expand our understanding of the process, and it is my hope and that a greater adoption of person-centered lung cancer screening principles can be one of the things that really transitions us to really maximizing the benefits of screening. Thank you for your time and your attention, and if there's any time, I'll be happy to answer any questions. I'm happy to stick around if folks want to stay a little bit longer, or we can close out here. Either way.
Hi, Dr. Stutz. Thank you so much. This was a fantastic webinar full of a wealth of information and resources. And again, on behalf of the Maine Lung Cancer Coalition and Quality Counts, thank you so much for your time and for doing this webinar for us today. It's really been terrific, and we can't thank you enough. So thank you.
Thanks,
so we can stay on for just a minute or so. Right now we don't have questions. If we have any questions in the next couple minutes, we will certainly present those to Dr. Stutz. If anyone has any questions after the fact, we have posted to please email at mlcc@mainequalitycounts.org, and we will work with Dr. Stutz to be able to get that information out to everyone afterwards. So one question we had, yes, will there be a recorded version available after today? Yes, there will be, and we will be sending that out along with the SurveyMonkey. It will be after the SurveyMonkey is completed, and that will be sent out to you as well as the slide deck. So absolutely. So thank you for the question. All right, thank you all very much for joining us. We'll ask all of you to have a wonderful day. Thank you again for sharing this time with us, and we hope to see you on our next Maine Lung Cancer Coalition webinar. Thank you so much. Take care, everyone.